Wharton professors in 2014 wrote a paper in which they said the consequences of reform would appear to be more moderate than has often been claimed. Opponents of the ACA, and by that they meant me, overestimate the coverage-adjusted sticker shock. There isn't much point in considering a premium or a pattern of coverage that no one buys. So, this is an argument you'll hear on MSNBC or from the White House that, look, I mean, yes, maybe there's some increase in rates from the old system, but the old system was terrible. They were junk policies. That's why the new system is better. And for all of that, they found that actually rates did increase by 14 to 28% based on their methodology, which was lower than what we found at the Manhattan Institute, but was non-zero. So I think that's an important point to mention. But their conclusion, and again I'm phrasing it in less polite language than they did, is that these opponents of the ACA who are consumed with hatred and not really thinking objectively about the law are saying that there's higher increases, that the ACA is increasing the cost of individually purchased health insurance by more than what the evidence would warrant. And so I thought I would address this set of contentions. First, I think we have to step back and think through some of the rationale behind the ACA and the problem the ACA was trying to solve. So the argument you heard a lot in 2009, and not just in 2009, was that we've got to do something about the uninsured because people's health care premiums or health insurance premiums are too high because there's all this uncompensated care in the emergency room. And because of all the uncompensated care in the emergency room, your premiums are high. And if we actually solve that problem and get everyone insured, your premiums are going to go down, and that's going to help everybody out. And in fact, President Obama famously, actually as a senator, as he was campaigning for president in 2008, argued that his plan would reduce the average family's health insurance premiums by $2,500 per year, and that was driven by the fact that uncompensated care would be less under his policies than what had happened before. But here's the interesting thing. You wouldn't know this from the amount of times this uncompensated care argument was made, but only 1.79% of national health expenditures is uncompensated care. And only a fraction of that actually involves low-income people who can't afford coverage and people who are denied coverage, say, because of a pre-existing condition and something like that. And there's another point that this chart doesn't even reflect, which is that these numbers, this figure of 1.79%, takes at face value what hospitals claim is uncompensated care. So if you're uninsured and you get a bottle of vitamins from the hospital and they charge $300 for it and you don't pay it, they list that as $300 of uncompensated care, even though the vitamins cost $1, right? They do this all the time. Steve Brill wrote his famous piece about this, A Bitter Pill, which I think illustrates a lot of the accounting gimmicks that go on in the provider community. So the uncompensated care problem, despite all the rhetoric around it, is actually not that big of a problem. What is a big problem? Healthcare is too expensive, right? So what this chart is plotting out is the cost of an individual or single policy as a percentage of per capita income. And it's gone from, in 96, about 10–11% to 18 to 19% in 2010. So obviously, as health insurance consumes a larger percentage of the household budget, that's going to put a lot of strain on a lot of people. And here's something else that's really interesting. Who are the uninsured? The uninsured are, of course, typically they tend to have lower income rather than higher income. But one big thing about the uninsured that often doesn't get a lot of attention is that the uninsured is predominantly young, right? So we know that it's very important to sign up the young for the ACA because they pay for everybody. What we don't realize is that actually a majority of the people who are uninsured in America are under the age of 35. 72% of the uninsured are under the age of 45. So the predominance of, what do we see? What do we see with the uninsured population? It's a typically healthier population because they're below average in age. They're a little bit lower in income, below average income, and they're often non-citizens. So typically citizens have a much higher rate of insurance than non-citizens or people who are immigrants to the country, whether legally or illegally. So here's the assertion that I really want to focus on, because I think it provides a pajama-clad blogger like me the opportunity to maybe critique some things that are often said in the ivory tower about the way markets work. This argument that there's not much point in considering a premium or a pattern of coverage that no one buys. Again, this is central really to the argument against the rate shock critique. It's that, well, who cares about the old system? They were all junk policies. And the comparison that the Manhattan Institute made, led by me, was we were looking at policies that were junk policies in the past and no one would want to buy, so it's an unfair comparison. So one thing that we have to understand about the market, we have to think actually, first of all, what is the market? The market is not merely this tiny slice of people who actually shop for coverage on their own in the individual market. So what's this chart showing? I know it's hard to read from the back. The red is for the commie single-payer side of the healthcare system, which is Medicare and Medicaid. This is the employment-based system, which is kind of in the middle because you don't choose your own plan. It's not a truly consumer-driven, market-driven system, though it has some elements of the private sector, of course. This is the uninsured population. This is the undocumented immigrant population that's uninsured. And this is the population that actually in 2013, pre-ACA, bought coverage for themselves with after-tax dollars. So what the argument that Pauly and colleagues are making here is that, well, you have to look at the policies that people actually bought in this market to understand what was truly the market. But of course, the market for a product is not merely the people who buy the product. It's also the population that don't buy the product but would otherwise be part of that market if the product were more attractive to them, right? So now some of these people, the uninsured, we should say for asterisk and completeness purposes, some of these people are people who had offers for employer-sponsored coverage and didn't take them for one reason or another. Some of these people are people who were eligible for Medicaid and didn't take it for one reason or another. But by and large, people in this group are people who are uninsured because why? Why are they uninsured? And that is a key to this question of what's going on, right? Because the market is not merely these people. It's the people who shop for insurance here or didn't because for whatever reason they found that the products that were being sold in this individual market up here were not attractive to them. So we actually have data on this very question. Why is it that the uninsured are uninsured? What are the concerns they've had about the policies that have been available to them? This chart comes from the Congressional Budget Office, which takes the data from the Survey of Income and Program Participation. And what do they find? They found by far the number one reason why non-elderly adults did not buy insurance was because of the high cost. It was not because insurance companies were mean and denied them coverage. Only 3.5% said that their health status was a reason for them being uninsured. So the cost is actually the driver. And so why did we look at the plans that were the least expensive in the old market and tried to compare them to the plans that were the least expensive in the new market, the ACA market? It was because the reason why these people are not buying insurance is not because they didn't like the fact that those plans didn't have maternity coverage or because the actuarial value was wrong. It was because the plans were too expensive and they felt that they couldn't afford those premiums relative to their perceived health risks. For whatever reason, they did what they thought was a rational calculation of, as much as I would really like to have health insurance, the prices of these plans, the premium that I have to pay every month, is too much relative to what I feel my actual health risk is. By definition, that is what they decided, or they would have bought health insurance. And so the market is not merely the people who bought the plans, it's the people who didn't buy the plans. And so what is the barrier to people not buying the plans? It's the plans at the lowest end of the market in terms of the premiums. That's what really matters to this population. And so what does the ACA do to address this issue? Well, actually, it applies a lot of regulations to the individual market that has the net effect, I think this is not disputed, of increasing the premiums in those plans. Now, you may think that all these regulations are a good thing because they end abusive insurance practices or because those practices were unfair. For example, one of the things that the ACA does is it prevents insurance companies from charging men different rates than women, and you may say this is just a matter of fundamental fairness, that's how it should be, even though men consume less healthcare services. I'm amenable to that argument. But the net result of that, economically, is that for men, the cost of insurance goes up. For young people, the cost of insurance goes up because they are being charged a lot more money so that people who are 62 can pay a little bit less, right? So these are things that the ACA does, and we can again have a debate about whether they're good or bad, but I think we all agree that these are things that the ACA actually does. And so the debate is not actually about whether these regulations increase costs. The argument that Pauly and Harrington are making is not actually that these regulations don't increase costs. They're implicitly making the case that these regulations are worth it. That, well, yes, they increase cost, but the welfare, the social welfare that comes from making these changes to the market is so good that the costs shouldn't be taken into account. That's effectively their argument. And that's not an argument, I mean, I think that's a different argument than the argument as to whether these things are actually increasing premiums, right? So you can, again, say that all these things are good. We should have policies that reflect all of these, what you might call consumer protections. But that doesn't mean they don't drive up premiums in the non-group market. And that's the point I'm trying to make here. So you can say the phrase you often hear in these debates is it's apples to orange, right? The old plans are apples, the new plans are oranges. You can't compare them because they're just so different that it's not appropriate to talk about the price. And, well, I would disagree. I think that both matter, right? So it's not just what the insurance plan covers or the richness or financial value of the benefit of that plan. It's also how much it costs. That actually matters. If you can get all of those changes that we talked about on this slide for free, that's great. But if they cost a lot of money, then maybe it's less great. And there comes a point where we have to think about what is the trade-off. And it's important to have an evidence-based, honest discussion of what we think is the appropriate trade-off. Again, whether you favor the regulations is a different question from whether they actually increase the costs. So here's an analogy I've used a couple of times to explain this. So let's say you're an environmentalist. I assume that there are many people in this room who are really concerned about global warming, and we need to reduce our carbon emissions to do something about that. Well, one thing Congress could do, if it were really concerned about global warming, is to require that all new cars sold in America have hybrid engines, right? We might consider that something that would be better for the world, that all cars have hybrid engines. Well, if you take a Toyota Camry that today, if you have it has a conventional engine, costs $23,000, and add in a hybrid engine, it costs 20% more. Now again, if you believe that global warming is this impending catastrophe that's going to destroy the world, then maybe that's not such a bad price to pay. Maybe it's worth making every American spend $4,600 more for a car because at the end of the day you're saving the world. You can make that argument, but you still have to acknowledge the fact that the price of the car has gone up, right? So again, the debate about whether the price is going up is different from the debate about whether it's a better world that we actually accept that cost, that the cost is worth it, right? And that's the point. It's not an apples versus oranges comparison to look at the conventional engine car and the hybrid engine car. Because, yes, they are different. But what we're trying to measure by looking at this price difference is precisely that cost. We're actually trying to measure what is the economic value of those regulations. What are they doing? And again, therefore, what is the benefit versus the drawback of that particular regulations? There may be regulations that really do a great job of improving the system or the world or a particular product or the regulation around a particular product that don't cost that much. Some others may cost a lot of money. In fact, regulatory agencies all the time make precisely those calculations when they determine whether to issue regulations or not. They have to think about, and some agencies are required by law to think about how much that regulation will cost the economy if they impose it. And they'll use those measurements to think about whether those regulations are worth imposing or not. So this is again to say, you can say it's apples versus oranges, but that is a normative claim. By saying it's apples versus oranges, you're making the claim that the system we have today is obviously better than the system we had before. And that is a disputable claim, whereas the cost difference is an empirical claim. So what did we actually find when we did this work at the Manhattan Institute? And remember that we, as Pauly and Harrington noted in their paper, we did take into account the fact of guaranteed issue. So this is actually adjusted for the fact that under the old market in most states, not all but most states, you could be denied a particular plan based on pre-existing health status. And we take that into account in adjusting for these numbers. But you can see that broadly speaking, we found a pretty substantial increase in the non-group, the average price of the 5 lowest plans available in the non-group market before the ACA and after the ACA. And again, as I said, we've been having this debate about whether or not that's the right way to look at. There are a number of different ways to look at this market. We looked at it this way specifically because our view was that the barrier to being covered if you're uninsured and unsubsidized is the premium. Because at the end of the day, all the other things about the plan don't matter if you're not willing to make that monthly payment every month to actually be covered. Now, here is an attempt to actually make an apples-to-apples comparison. This comparison wasn't made by me. It was made by Sam Richardson at the University of Texas. And he looked at 2 plans that are very interesting in how similar they are. And the reason why this is so interesting, these are 2 plans from Sacramento for a male of average age who's a non-smoker. And they're both Kaiser plans. And the reason why that's really interesting is because one of the differences between a lot of the plans on the exchanges and some of the pre-ACA plans is network design. And Mark and Scott talk about this in their paper, that's a big part of something that people should think about in terms of how the new plans are different from the old plans. But here, Kaiser, of course, being an integrated institution, the networks are the same. In both of these plans, you're using the Kaiser network. The networks are actually identical. What else is identical about these plans? The actuarial value of the plans is almost the same, 60.5% for the 2013 plan, 60.4% for the 2014 plan. The deductibles were the same. The out-of-pocket maximum was actually higher in the 2014 plan. There are a couple other differences. There are no prescription drugs in the old plan. Some of the copays are higher in the 2014 plan, like for the ED. And these effects, netly speaking, I've spoken to actuaries about this. These effects are basically, by and large, a plus or minus, depending on the differences, about 10 or 20 bucks. It basically evens out, broadly speaking. You might give this plan another 10 bucks of value if you change, if you take into account the difference in the benefits in this laundry list over here. But what's the difference in price? Right? It's almost double. So these are, again, plans with identical networks, identical actuarial values, pretty similar cost-sharing provisions, and yet the plan is twice as expensive. So if the argument is that the old plan was junk and the new plan is great, well, again, that may be true for someone who had a pre-existing condition. That might be true for someone who was, say, 62 years old, who's now getting an age rating that they didn't have before because California didn't have age rating pre-ACA. California did have gender rating. So in California, prior to the ACA, you couldn't charge women a different rate from men. So the point is, what's driving this big difference? It's a lot of those regulations that we talked about in the ACA, and they have nothing to do with some of the things that you often hear people claim are the drivers of the cost increases or the premium increases in the ACA. So let me attack this assertion in another way. So the claim is that there's not much point in considering a premium or pattern of coverage that no one buys. So that statement is kind of it's a throwaway line in the paper. There's not a lot of discussion of what exactly that entails. But fortunately, we actually have evidence in the literature as to the kinds of plans that people did buy in the pre-ACA individual market for health insurance. There's a nice paper by John Gable and colleagues at the University of Chicago that was published in Health Affairs that looks at precisely this issue of what are the actuarial values of the plans in the ACA in the plans that in the actuarial values of the plans pre-ACA versus post. Now, of course, as you probably know, plans in the post-ACA regime have to have actuarial values effectively above 60%. That's this barrier right here. So it turns out that more than half the plans that people actually bought in the old individual market had actuarial values below 60%. Those plans are now illegal. right? So if the argument is, well, people didn't actually buy these plans, they were all junk policies that people didn't like, well then that's not what the evidence shows. The evidence shows that actually these plans were popular and people like them. And that's why, one of the reasons why the ACA is unpopular today is because there are a lot of people who own these policies, right, whose plans were canceled because they're now illegal. And this is purely on actuarial value. This is not on whether they had maternity benefits or whatever else, right? This is just on AV. Here's the other thing that's just basic common sense, right? If all these regulations were doing or facilitating the plans that people actually wanted to buy, then the regulations wouldn't have been necessary. People would have organically been buying those plans on the old market already. But the fact is they weren't. They weren't merely buying the plans that conform with ACA's regulations. Some people were buying those kinds of plans, but a lot of people were not. And so it's not actually true that these were plans that no one was buying. Plenty of people, more than half of the people, were buying plans that are now illegal. And you wouldn't need an individual mandate to require that people purchase these plans if you thought that they were plans that people really wanted to buy. You wouldn't need to force them to, right? Now, yes, there are all sorts of issues around adverse selection when you change the market around, and we can talk about that in more detail. But about this specific assertion that the old ACA, the pre-ACA plans don't matter because no one bought them, it's empirically not true. Now, what is the problem? Right? Why is healthcare so expensive? Now, of course, for this extremely accomplished and sophisticated crowd, this is old hat, but I still want to talk about it a little bit. Because I think there's something interesting that I think this is original research by us. If you actually try to calculate the scale of the employer tax exclusion and compare it to Medicare, Medicaid, and the ACA exchanges, it's actually larger now in terms of lost revenue to federal, state, and local governments relative to Medicaid. So it's actually the second largest entitlement in the country. And why is that important? You all know the reason. I mean, basically what's happened is between Medicare and the employer tax exclusion, you have all these people who are massively insensitive to the price and value of the care they consume, so they consume a lot more of it. And this is what we get. We get a system where the median cost of a hospital day, a day spent in the hospital in the United States, is 5x that of a typical Western European country. That's despite the fact that the actual length of stay, the average length of stay in the US is actually shorter. So people actually spend less time in the hospital in terms of both the length of stay and actually the number of admissions relative to Europe, and yet those admissions cost way more money. And that's not driven primarily by utilization. It's driven primarily by price. And that's very important because sometimes that gets lost in a lot of our discussions about what makes healthcare so expensive. You hear some people, no one in this room I'm sure, argue that healthcare is expensive because of the profiteering of insurance companies. But what's really driving expensive healthcare is what hospitals and doctors charge for healthcare services. And that in turn is driven by the fact that the patient has no economic incentive or no direct economic incentive to actually be cost conscious. It's like an open bar versus a cash bar, right? If I go to a cash bar, maybe if Leonard Davis Institute's having a reception and I have to pay $6 for the house wine versus something nicer, then maybe I get the house wine, right? But if it's an open bar, particularly if Paulie is paying, I'm getting the single malt scotch, right? So that is the economic phenomenon that's at work here. Here's something else that's important that, I've been spending a lot of time talking about the individual market, but let's for a minute talk about Medicaid, because I think, this will help you understand where I've been thinking about health reform broadly and what we ought to do about this general set of problems. So this is a chart from the Center for the Study of Health System Change, and they did a big survey of physicians, and they looked at by insurance status. So private insurance is the dark blue, Medicare is the light blue, and Medicaid is the orange. And this is 6-year-old data now, so these gaps have widened over time. A lower number is better. So what this is showing is the percentage of physicians who are accepting no new patients by insurance status. So if you have private insurance, most doctors will take you. No one's rejecting you. If you are on Medicare, more and more doctors are, and if you're on Medicaid, the numbers are much higher. And so what does this mean? This means that just because you have a card that says you have health insurance doesn't mean you're actually getting access to the care that you need. And this is why all the literature shows that Medicaid health outcomes, even when you normalize for income, race, and other socioeconomic factors, do poorly, very poorly compared to private insurance, and not much better, if at all, relative to being uninsured. It's because at the end of the day, the system we have today incentivizes physicians to reject Medicaid patients and increasingly Medicare patients and focus on the commercial insurance population, commercially insured population, because they reimburse at higher rates. That's not the only factor, but it certainly is the most important factor that's driving these disparities. And so the ACA, by expanding Medicaid for the poorest and most vulnerable population, ironically, is actually consigning those individuals to a much lower standard of care and coverage than the people who are eligible for coverage on the exchanges. And of course, as we all know, that was done for fiscal reasons, because expanding Medicaid is cheaper than exchange-based coverage. But cheap doesn't necessarily mean more cost-effective. You know, a Yugo is cheaper than a Toyota Camry, but that doesn't mean a Yugo is more cost-effective to buy than a Toyota Camry, because it might break down 5 times a week and you'll have to replace it, right? So what's the other big problem? And of course, again, this is old hat for the sophisticates in this room, but I think it's worth still touching on. If you actually take the Congressional Budget Office's long-term fiscal projections, and these are the most recent projections, what do they show? So you hear all this stuff and you read all this stuff, and maybe some of you even written these papers about the great health spending slowdown, how it's not a problem anymore, Medicare is only growing at 0 or 1%, or even negative in some metrics, so it's not that big of a deal, we don't have to worry about this anymore, everything is fine. Well, the Congressional Budget Office, which monitors that data very closely and takes it into account in formulating these projections, still projects that because as the baby boomers retire, we're going to see a rebound in the growth of federal health spending, that this is still the dominant factor in all of our fiscal conversations. Actually, what's really remarkable about this chart is that everything else is basically flat as a share of GDP over a longitudinal basis. So that's Social Security, the military, unemployment benefits, food stamps, NIH, whatever it is you think the government should or shouldn't be doing, that part of the budget's actually fine. It's pretty manageable, which is actually, to me, I think that's pretty good news, right? That's encouraging. But this part is the part that's causing all the problems. And that's actually what got me into this business. Well, that and this. The interest on the debt is also growing as a share of GDP according to CBO. But my point is that why did I, a guy who was just minding his own business on Wall Street, try to get involved in this line of work, is because of this problem. I felt that my team, the Republicans, weren't doing enough to really get into this problem and what to do about it and how to solve it. Because at the end of the day, if we get to 2050 on this chart, it's not going to look like this anymore. We're either going to have a fiscal crisis or an economic crisis or a banking crisis or all three at the same time. And who's going to be hurt? It's going to be the people who actually depend on these programs, the most vulnerable people in our society. So this is something we absolutely have to address. And whatever you think of this health spending slowdown or what's causing it, and there's all sorts of debates in our community about that, the fact is, at the end of the day, it's not, the slowdown still doesn't mean that we're out of the woods. Not by a long shot. Health spending is still by far the biggest problem that we have. So I touched on this already. It's hospitals, not insurers, that drive high health costs. So this goes to the question about the managed care and their role in all this. So what happened in the 90s? Managed care increased its penetration pretty substantially. And what's this chart showing? So this chart's trying to overlay two things at once. The first is the blue, the number of hospital M&A transactions in a given year. And then the red line is looking at the Herfindahl-Hirschman index for the average for the median hospital market, right? So a measure of hospital market concentration. And what happened? So managed care comes in, tells the hospitals where they can stuff it, and hospitals go back and say, here's where you can stuff it, insurers. We're going to merge and use our market power to charge higher rates so you can't do anything to us. So there was gigantic change in the median HHI in the 90s. Then it petered out for a while, but it's coming back up again right here, right? Part of that is driven by providers or hospitals buying up physician practice. Part of that's the ACO stimulated the integration. And part of that is just, well, if the government's going to be more involved in the system and their rates are going to be lower, we might as well consolidate more so we have more leverage over the private payers to squeeze every last penny out of them. So this is a huge problem, and I would argue the biggest problem in terms of tackling the high cost of health care is the fact of the large power, the big power of providers, of hospitals. And at Yale New Haven Hospital now owns basically every big hospital system in Connecticut. Almost all of them are owned by Yale New Haven. They even bought their crosstown Catholic rival, St. Raphael's, last year. So they basically control the whole market. So if you're an insurer, even if you have a monopoly in that market, there's not a lot you can do to tell Yale New Haven what they should charge. Here's a map of HHI by David Cutler and colleagues that was published in JAMA, and you can see the dark red is the most concentrated, the light red is the unconcentrated part. Where the concentration is here in Pennsylvania, it's kind of bad in this North Jersey area particularly, but this is a problem that's getting worse and worse all the time, and it's not an easy problem to solve with conventional means because the insurers really don't have, unless they become monopolies themselves, the ability to really have leverage over these large hospital systems. What does the ACA do? Well, aside from the regulations that we talked about, it subsidizes the cost of coverage for people who are uninsured. And this is a thing that gets conservatives going. Conservatives say, well, we're already going broke because of health care spending, and now we're adding all this additional spending. And this is why, you'll hear conservatives often talk about, when I give this talk to conservative audiences, conservatives often like to say, conservative politicians especially, this is the government takeover of the healthcare system. It's Obamacare, and it's because of, they look at this data, the amount of spending, right? $250 to $300 billion a year, which is a lot of money, even in Washington. So, is there a better way? Of course, I wouldn't be coming up here and complaining so much if I didn't think there was a better way, but then again, there are lots of Republicans who complain about Obamacare who don't talk about whether there's a better way. So I feel like it's up to me to do at least my small part to have that conversation. But let's start with this chart, because a big part of the challenge here, and I was mentioning this a little earlier before I came into the room, why am I giving you this talk? Why aren't there 1,000 other more accomplished and experienced conservative health wonks up here giving you this talk? On the left, I could never just walk in and drop in and give you this talk because there'd be 20 professors at Penn who could give this talk better than me, at least, right? But why am I here? Because conservatives haven't really paid attention to this issue, and there are some reasons about that we can go into. But what is it that conservatives get worried about? They worry about the spending, and they say, Obamacare, it's the government takeover of the healthcare system. But if you change the y-axis on this chart, right, and then layer in what the government was already spending on healthcare, well, if Obamacare is the government takeover of the healthcare system, what's all this, right? And not only that, but if you repeal Obamacare, which would be considered this great triumph, right, which I think is never going to happen, but let's just humor Ted Cruz for a moment and say that we're going to repeal Obamacare and maybe replace it with some half measure that spends probably a comparable amount of money, but maybe a little bit less. What have you done for this problem? If you're a conservative and you really care about out-of-control government spending, you haven't done a darn thing about that problem, right? So this chart is what I use to explain to conservatives, look, you can hate Obamacare all you want, but the problem is much bigger than the Affordable Care Act. The problem predated the Affordable Care Act. And whatever one thinks of the ACA, in order to address the problem, the solution has to encompass things that are not, the ACA can't be the center of the solution. The solution has to center around the entire problem, not just what one might critique about the ACA. So this is probably the most important chart I'll show you today, or at least from my point of view, what I think is the most important chart. So all of you have memorized, I'm sure, the OECD chart that looks at spending as a percentage of GDP of all the different countries in the world and how we spend the most, and we don't have universal coverage and our health outcomes aren't so great, blah, 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 blah. What this chart is showing is something a little different. It's showing government spending, public health expenditures per capita. That's federal, state, and local in the U.S. context, and varies on the country because some countries have similar systems in that regard. But look at this. Before the ACA subsidies went into effect, the U.S. government spending per capita was higher than all but 2 other countries in the entire world. Government spending. So we spent a lot of time talking about overall spending, right? But if you're a conservative and you believe we had a free market healthcare system before Obamacare, well, look at this, right? We didn't. We were spending more than all these social welfare countries that we like to make fun of and say, you know, if you read National Review all the time, as I do, maybe I'm the only one in the room who does, but you know, you hear this commentary all the time about how all these European countries are going broke and we don't want to be like them. Well, if we had their healthcare systems, we'd be going a lot less broke, right? And this is an argument progressives make all the time, that, well, we would save money if we had single-payer healthcare because we could have price controls and rationing and force these hospitals and doctors to charge more reasonable prices for their services. And that's all true. We would spend less money if we had a Canadian system or a British system. But those aren't the only comparators. I think one thing we often forget on both sides is that not every European country or every industrialized country in the world, just because they all have universal coverage, doesn't mean they achieve that in the same way. Universal coverage is not the same thing as single payer. That's a fallacy that's made both on the left and the right. So the right thinks universal coverage means single payer. That's why they oppose it. They oppose universal coverage, I mean. On the right, it said, well, universal coverage is the same thing as single payer. That's the only way to do it. Well, that's not true. And that's what we're going to get to in a minute. So first, again, this is something I always have to present to conservatives. This is, I think, obvious to this crowd, but it's actually pretty amazing. In conservative circles today, it's considered outre to claim that the ACA will never be repealed. Now, in 2013, Ted Cruz went all over the country trying to shut down the government because he stated that if we don't repeal or defund Obamacare now, once the subsidies go online on January 1, 2014, it'll never be repealed. That's what he said in December 2013. In January 2014, he very seamlessly flipped into a different argument, which is that we can still repeal every word of Obamacare and everything's going to be fine. And that's now what pretty much every conservative Republican says, not just in terms of politicians, but also in the think tank community. It's pretty remarkable, actually, how many think tank people who you'd think would be more pragmatic or realistic about that stuff or sober about it say, yes, we're still going to repeal Obamacare. Now, this is the Congressional Budget Office's estimates of how many people will be on the Medicaid expansion and the ACA exchanges over time. Now, this includes previously insured individuals who had maybe coverage under the old individual market or maybe the employer market or whatever. But the point is, if you're going to repeal Obamacare in 2017 when 37 million people are on these kinds of plans, I mean, Hillary won't even have to launch a campaign, you know? She won't. She can just kick up her heels, sit on the desk and run ads all day featuring people who have these plans and are having it taken away by Ted Cruz or Marco Rubio or whoever it is. So now, the CBO might be overly optimistic, and if you talk to senior officials at HHS or CMS, as I did just the other day, they are trying to downgrade these expectations. They're really worried about meeting these CBO expectations for 2015. But let's say it's 20 million, not 37 million. That's still too many. I mean, there's no way you're going to take health insurance away from 20 million people. And of course, they're not trying to take it away. They're going to say, well, we have something better. We're going to give you some better plan. But you're asking that voter to trust you as a politician that you're going to give them something better than what they already have and might be happy with. And as President Obama rightly said, why did he campaign on it? If you like your plan, you can keep it. Because he knew that was toxic. And Republicans have rightly given him a lot of crap for breaking that promise, but they're going to turn around and do that to 20 or 30 or 40 million people? I think not. Something you hear Republicans hang their hat on as well, the public continues to oppose the ACA or have an unfavorable view of it. And that's true. They do. That's been an enduring quality that's surprised a lot of politicians. A lot of people, Nancy Pelosi most famously said, you have to pass the bill to see what's in it because as you see what's in it and see all the great things in it, you're going to like it more. It's going to be more popular. Well, that hasn't played out. But here's the interesting thing. Yes, the public doesn't like the ACA, but they also oppose repeal by a factor of 63 to 33. Now, of course, that splits out by a party, but look at independents. 59 to 38 oppose repeal, even if that repeal involves replacing it with something else. Now, of course, you can phrase this question differently and get different answers, and I'll let the political scientists argue about that. But I think this general pattern holds, which is that Americans may not think the ACA is going to live up to the hype, and I would agree with them on that. But they also are very skeptical of additional disruption of the health insurance system. They've gone through enough disruption for 1 decade, right? They don't want to go through another round of disruption. They want to solve the problems that exist in the healthcare system, but not unnecessarily disrupt healthcare where it's not needed. And so again, if we go back to this chart here, what's a possible alternative to repeal and replace that Republicans could pursue? Well, one thing that's very interesting about this chart is the countries at the bottom of the list. 2 of them in particular I'd highlight because I think they're very interesting as models for where conservatives could go and ought to go on health reform. And a lot of this is actually due to Mark Pauly and Scott Harrington and their colleagues, which is, if you look at Switzerland, what is the kind of healthcare system that Switzerland has? What's the kind of system that Singapore has? They're spending a lot less in terms of government spending on healthcare relative to the U.S. Now, Swiss overall spending is more in line with mainstream European spending. Singapore still is much lower than everybody else's. But from a fiscal standpoint, if you're concerned, as conservatives are, with what the government's liabilities are for healthcare spending, this disparity is very impressive. And yet these are countries, again, with universal coverage, really good health outcomes, long life expectancies, all the things that you would want. Not only that, they don't have the queuing. You're not waiting 14 months to get a knee replacement in Switzerland. You do have access to high-tech medicine, MRIs, the latest drugs, et cetera, et cetera. So what are they doing right that we can learn from? Well, again, as I mentioned, not all countries that have universal coverage are the same. The UK is the closest thing to a true socialized system. They own the hospitals and employ the doctors and control the insurance company. France is actually, if you add up all the things the French do to their healthcare system in terms of government involvement, they're about the same as the U.S. in terms of the level of government involvement in their healthcare system. That's not what people perceive. People perceive of France as much more government activist, but in terms of healthcare, it's actually not that different if you add it all up. But look at Switzerland and Singapore. So they have some interesting things we can learn from. What does Switzerland have? Switzerland has basically the Obamacare exchanges for everyone. There's no Medicare, there's no Medicaid, there's no employer-based system, there's no public option, there is an individual mandate, there's a certain amount of price regulation, but generally speaking, what is Switzerland? It's the ACA for everyone. What does that mean? That means if you have low income, just like the ACA exchanges, your premium is fully subsidized. If you're low or middle income, it's partially subsidized. If you're upper income, it's not subsidized at all. And that actually has been a model for a lot of the health reforms that people like Mark and others have been advocating for a long, long time. Singapore has a different model, but a very interesting model. And what's really interesting about Singapore, too, is a lot of people in the academic community don't write about Singapore, don't study Singapore, because Singapore is not a member of the OECD. So when you see all these international health comparisons, almost everyone uses OECD data because they do it all this time and it's just the easiest thing to do, right? Well, Singapore's impressive performance has left out a lot of those studies and a lot of those comparisons because they don't report their data to the OECD. You have to go to the World Health Organization and other bodies to find the Singapore data. But if you compare it in there, it's really, really impressive. And William Hazeltine, if you're interested in learning more about Singapore, Bill Hazeltine, who's at the Brookings Institution, has written a nice book you can download for free from the Brookings website called Affordable Excellence that goes into a lot of detail about what Singapore does. What do? They have single-payer catastrophic coverage combined with mandatory HSAs. So they take our equivalent of the Medicare payroll tax, and instead of giving that to the trust fund and all these agencies, that money is redeposited in your health savings account. There's a little bit of adjustment for means testing and things like that, so low-income people get a little more, high-income people get a little less. But generally, for non-catastrophic expenses, Singaporeans are shopping for services on their own. And it has worked extremely well in Singapore. And so you can say, well, the Swiss population and the Singaporean population, they're different from the US population. That's true, but that demographic difference doesn't account for the gigantic difference in fiscal efficiency of these systems relative to the United States. So how do we think about in the context of what the ACA has done? So I showed you this chart before about what the U.S. used to look like pre-ACA. What does the ACA do? It expands Medicaid, and it creates this regulated individual market that I was complaining about in the beginning. Now, so when I look at this, as much as I was complaining about it, I do like one thing about the ACA's individual market idea, which is I think it's better, like with the open bar versus the cash bar, I think it's better when people control the money. The more consumers control their own healthcare dollars, if you want to have a patient-centered healthcare system, that's a big buzzword in our world, right? There's one very simple way to have a patient-centered healthcare system. If the patient controls the dollars, the healthcare system will revolve around the patient. If the insurance company and the government control the dollars, the healthcare system will revolve around them. It's not rocket science. And this is something I think we can build on. Now, here's some other encouraging news. So I've spent a lot of time complaining again. Let's talk about some of the good things. So actually, outside of the aegis of government, there's a lot of movement towards consumer-driven healthcare. Large employers are going to start moving to these private exchanges that are privately sponsored by groups like Towers Watson and the like, where you basically, as a large employer, like Walgreens is doing this now, you give everybody a certain amount of money, like $5,000. You give them a set of plans they can choose from. If the plan costs more than $5,000, they pay the difference. And that's a way to have fiscal certainty around what your healthcare spend is as a corporation. Why is that really important now? Because the Cadillac tax starts to kick in from the ACA, and so you really want to pay attention to how much you're spending on healthcare, because over time, that Cadillac tax becomes a Buick tax and a Chevy tax and bites into your healthcare spending more, and you want to make sure that the trajectory that you're using is amenable to that and compatible with that. And over time, what does that mean? It means that you actually have the fiscal certainty again of how much you're spending on healthcare, and then letting the consumer introduce the discipline into the plans that the consumer chooses. What else is happening? HSAs have exploded. So in Washington and in academic communities, HSAs are still seen as these exotic instruments that are only for the wealthy and the healthy, and why would anyone want an HSA? It's really terrible. HSAs were basically legalized with the Medicare Modernization Act of 2003. Next year, 82% of large employers, so large employers here is defined as employers with more than 1,000 workers, 82% of those employers are offering HSA or HRA-based plans. 30% is the only option, 44% is the default option. So in a very short period of time, HSAs have become a dominant player in the way people who work for large employers consume health care. So while, again, in the policy community this may be seen as some exotic creature, in the private sector, this change has happened very, very rapidly, and there are a lot of people out there who are using account-based systems to pay for health coverage. So you put all this together, the fact that the ACA introduces expands the individual market for health insurance, the fact that both large employers are both using private exchanges and HSAs to put patients more in control of their own health dollars. And what can you do with this? You can basically have, I call it the Switzerland model here, it really could be the Mark Pauly model, which is basically take the Swiss health system and apply it to everything in America. Now that we have the ACA exchanges, which are modeled after Switzerland, why not gradually migrate the Medicare and Medicaid populations into those exchanges? That would be a very simple way to reform the system fiscally and focus our scarce healthcare resources on the people who really need them, the poor and the vulnerable and the sick, the low income, right? And what's so ironic about the healthcare debate we've had in this country is you all are familiar with all the screaming and yelling that's been going on. But the actual policies that have been advocated by Democrats and Republicans that have induced the most yelling by the other side are almost identical. Right? So the Paul Ryan plan to reform Medicare and throw Granny over a cliff into the freezing gorge below is actually a plan to use insurance exchanges to allow premium assistance payments for seniors to buy private plans. Exactly what the ACA exchanges do. There's actually a couple of differences between the Paul Ryan Medicare exchange and the ACA insurance exchange. One is Paul Ryan's plan has a public option. The ACA exchanges don't. Another is that the ACA exchanges are means tested. They only apply to low-income individuals. The Paul Ryan plan's for everybody. So it's federal spending on rich people, not just poor people. So I look at those two plans and I say, if I had a choice between gradually migrating the over 65 population onto ACA exchanges versus Paul Ryan, I'd take the ACA every time. It's actually, as a conservative, a more conservative outcome. It spends less money, and it doesn't have a public option. And so the ACA, a very simple idea for what I think would be an interesting healthcare system is, let's take advantage of what the ACA has introduced at great effort and cost and use it as a mechanism for system-wide entitlement reform. And what could you do? You could then, because you're focusing our resources on the low-income population, actually do a better job of serving that population and making health insurance less expensive and more affordable for that population. So basically, I would take this entire thing and turn it into yellow and turn it into the individual market. How would that happen? Well, it's a simple four-step process, and there's a lot of wiring under the hood. If any of you have actually slogged through my 68-page plan, you'll know this. But the overall arching framework is pretty simple. Make some liberalizations to the way the exchanges work so that carriers can compete on a broader range of attributes than they can today. Today, on the ACA exchanges, basically you can only compete on two things. One, how much you pay doctors and physicians and hospitals. Two, which hospitals and doctors are in your network versus out of the network. That's basically it. You can't really compete on what's covered in the plans. You can't really compete on actuarial value, etc., right? So that's one way to do it. I think there are ways to liberalize the ACA exchanges that increase competition and lower cost. So for example, one thing that the ACA does is it requires all plans in the ACA exchanges to cover branded drugs, even in areas where it might not be an evidence-based, there might not be an evidence-based rationale for a branded drug being reimbursed for a particular therapeutic area with a particular disease. But these insurance plans have to cover that. Why is that? Why not let plans compete on a better way to do that, you taking advantage of all the generic drugs that we have? That's one example of many of what you can do if you liberalize the ACA exchanges. You gradually raise the eligibility age for Medicare, 4 months a year, forever. What does that do? That means people who are on Medicare today, they're grandfathered. They stay on Medicare. But someone my age wouldn't be on Medicare until his early 70s. To me, I don't see that as a big deal because it's either that or Medicare's broke. So either way, you know, it's a win-win for me if that happens. And not only that, remember, we're not abandoning the low-income population. They would be eligible for subsidized coverage on the ACA exchanges. So upper-income retirees might have to stay in the workforce or pay for their health coverage on their own, but lower-income retirees would be protected. You can do a lot of things to improve Medicaid. So one of the ideas that's been around for a long time, actually John Holohan of the Urban Institute was one of the guys who proposed this, also the Bipartisan Policy Center with Alice Rivlin and Pete Domenici. They said, let's think about the idea of swapping out Medicaid. So right now Medicaid, as you know, is a big mess. One thing you could do is you could have the acute care portion of Medicaid completely funded by the federal government and have the long-term care portion of Medicaid completely funded by the states. You could also do it the other way around, but for various reasons it doesn't work as well if you do it the other way around. And so I adopt that Holohan model and say we can get rid of a lot of the inefficiency in Medicaid by actually federalizing acute care, by simply taking that Medicaid population, putting them on the exchanges, and giving them the same cost-sharing subsidies that a person, say, of 100% FPL on the exchange would get today, and return LTC responsibility to states, though with the maintenance of effort provision requiring them to spend the same amount of money that they would have had to spend otherwise, but otherwise give them the autonomy to run the long-term care programs the way they want. And then there are other reforms, which I'll get into a little bit more in a minute. So what would this look like in more detail? So this is kind of the overview. What's some of the wiring under the hood? So one of the things I do in this plan is I repeal the individual mandate. My argument, and this is backed up by the modeling we did using Steve Parenti's microsimulation. Steve Parenti, as most of you know, is an economist at the University of Minnesota who, like a lot of guys, has his own microsimulation to do this kind of work. He modeled that if you actually repeal the individual mandate but replace it with a limited open enrollment period, so in this plan it's 6 weeks every 2 years instead of, say, 2 months every year, and you get rid of, or a big chunk of the adverse selection by allowing young people to buy health insurance that's more attuned to their actual health risks or actuarial risks, you can actually do a lot to encourage young people to enter the market without having to force them to do so with an individual mandate. Another thing that this plan does is for the population that's getting subsidized coverage, of course there's the unsubsidized population and the subsidized population, the population that's eligible for subsidies, the benchmark plan would be a catastrophic plan with an HSA, so something more like what Singapore does. And what's the advantage of that? It means that for the first time in a lot of cases, this low-income population is going to have the opportunity to save money over time. They're going to have an economic reward for staying healthy and making sure that they're in the hospital for the things they really need to do, but otherwise they can build a nest egg, they can have a future, they can pass it on to their children. That's something they don't have the opportunity to do today. When you raise the Medicare eligibility by 4 months a year forever, one thing that happens, it's actually incredibly undisruptive. Think about it this way. If now the Medicare eligibility age is, say, 68, and you're 64 today, well, whatever plan you're on when you're 64, you can stay on it when you're 65. Instead of being forced to join Medicare today, you're forced to enroll in Medicare, or you forfeit your Social Security benefits. Instead, you can stay on your employer-sponsored plan if you want to stay in the workforce. If you want to retire, you can buy insurance on your own, and if you're low income enough, you can buy that coverage in a subsidized format on the exchange. But because it increases the incentive to remain in the workforce, it has a powerful fiscal effect by increasing the solvency of Social Security. And the net effect is to means test Medicare, the Medicare benefit, the equivalent of the Medicare benefit for future retirees. And also, there's some other things we can do that a lot of the bipartisan commissions have talked about doing in terms of broader Medicare reforms for the legacy Medicare program. What would the Medicaid reform look like? So I talked about this a little bit, and I think I emphasized this point about how you can actually increase the wealth of the low-income. One thing that we talk about a lot, we talk a lot in this country about income disparity. We don't talk as much about wealth disparity. The real gap between the poor in America and the middle class is not income, it's net worth. And that's something that's very important to address. And one of the things I really am passionate about is trying to do more to encourage the low-income population to have savings accounts, to have bank accounts, to have savings accounts, to have that feeling like if I save money and actually do the right things, my future can be better. Because if you just give people a health insurance benefit and say, you know, we got you covered in case you get hit by a bus, well, that's great, but that doesn't actually mean anything for my future. Yes, it means that I'm insulated from going broke because I get hit by a bus, but this is a pretty low-income population to begin with, right? Going broke is, they're already pretty poor, right? The big issue is what is the future? What does the future look like for this population? And yes, is it hard work to maybe teach low-income people who have never had a bank account before how to have one, how to save money? Of course. But isn't that the work we should all be doing to begin with? Isn't that, if we want to lift people out of poverty, the kinds of things we ought to be doing for this population? And wouldn't that actually have a distributional effect on their health care? Of course it would. So there's a lot of things you have to do. The reason why you have to do the swap and not just federalize everything is because you have to make it fiscally neutral at some level. And there's a lot, this is going to be, from a legislative standpoint, if this were ever to be a bill, the most complicated part, because every state is different, every state's population is different, and the plan tries to take that into account to say, okay, let's make this reasonably equitable for different states with different types of populations and different long-term care programs. But the idea here is generally speaking, if you can migrate the current gamish into a system where one entity, the federal government's responsible for the acute care side, and one entity, the state government's responsible for the long-term care side, both systems, both entities would have the incentive to run those systems optimally, or at least more optimally than they do today, where they basically spend all their time passing off costs through accounting gimmicks to each other in ways that make the system less functional rather than better. We definitely have to attack the problem of high provider costs. Now, I know a lot of people love the ACOs and all this kind of stuff, and there's delivery system reform, and everyone talks about it. But really, if we're honest with ourselves, we have to go a lot farther in tackling the problem of high provider prices. And one thing that I propose in this plan that I'm sure my libertarian friends won't like is I actually say, if you are a hospital monopoly and you don't want to break yourself up into your component units, then we ought to treat you like a regulated utility. Now, I don't think we should go all the way to single-payer monopsony power, but I actually do think that you should have two choices as a hospital. You can either compete with your rivals on price and quality. That's what I would prefer. But if the, if the horse has already left the barn and you've already swept up, you vacuumed up all your competitors, and you don't want to spit them out again, or maybe you've closed the other ones down, then we have no choice but to treat you like a utility, because what the prices you're charging are basically being paid by private individuals and taxpayers in the form of high premiums and high taxes and high deficits. So what's the way to attack that? Use HHI. So the measure of market concentration. If you say it's above, say, 4,000 or 5,000 in a particular area, then you're going to have to pay Medicare rates. You're going to have to accept Medicare rates from every payer, whether it's a private insurer, an uninsured person, whatever it is. And that creates a certain amount of transparency around prices too, because you can find out what Medicare is paying for each of these procedures in that particular area. So that way, it creates not only is that good from a cost control standpoint, it also creates a disincentive for further consolidation, because today hospitals know that if they merge, the FTC might give them a hard time, but probably won't. The odds of the FTC or the DOJ challenging your merger are pretty low, so you'll get away with it in most cases. But if you do it this way, it creates an organic disincentive for hospitals to merge, because there will be an automatic barrier upon which, if they hit that, boom, they have to accept Medicare rates from everyone. And that creates an economic disincentive for them that doesn't require a court battle. So I think that's something that I've introduced here that I've found a lot of bipartisan interest in. But should we do more on hospital antitrust litigation? Absolutely. Let's beef up the antitrust efforts in that regard. Let's use some of the other tools like medical tourism and reference pricing to allow more price signals to come out and to allow people to go where they're going to get the most cost-effective care. Let's bring veterans into the exchanges and allow VA hospitals to admit civilian patients. So Philip Longman and Paul Krugman, all these guys think the VA hospitals are really great and they provide the best care around. So why not let them admit civilian patients? Let's allow, if they're so great, civilian patients to access that high-quality health care in the VA hospitals. Now, if it turns out the VA hospitals are not so great and they are actually having a lot of problems, then, well, that will come out. But let's instead of debating it in centers like this, let's actually let civilians go where they think they're going to get the best care. We don't need the employer mandate. This is something that, again, think tanks on both sides and academics on both sides and the CBO have all agreed that the number of people with health insurance is unaffected by whether there's an employer mandate or not. And I actually see this as something that could be an area of bipartisan interest in the next Congress, particularly if Republicans take the Senate. Should we do more stuff around malpractice? Absolutely. Though it's complicated now because actually, I don't know if as many of you know this, on the right there's been a critique of federal malpractice reform that it violates the 7th Amendment because the federal government, it should be states that actually do malpractice reform, not the federal government. So in my plan, I keep it, the rhetoric on this is relatively vague. It's about, let's see what we can do that's consistent with those 7th Amendment concerns. But this is an area, obviously, we got to do something about, though, as I think you would all agree, it's not the silver bullet that a lot of physicians believe that it ought to be. And I think we should spend more training residents and bringing them in from other countries. If we do that, we can address the big physician shortage. Now, that's not the only part of things. We have to, I think it's okay to use registered nurses and PAs and use more cost-effective providers to deliver care. But do we have a shortage? Absolutely. And let's try to do something about that. And there's enough room fiscally in this plan that it's not that expensive to turn this, what we now do through Medicare and Medicaid and the VA, make that a discrete congressional appropriation and focus on improving the quality and the volume of people that we're training for House staff. So what did Parenti's model spit out when we made all these changes? Now, we went through about 14 iterations of the plan to get to this result, which I think was a useful intellectual exercise because it allowed us to really think through the trade-offs of different types of approaches to health reform. But what we found is, over 3 decades, the deficit reduction is pretty strong. This is a reduction of $10.5 trillion in spending and $2.5 trillion in federal tax revenue. And why is that? So in the first decade, it's basically fiscally neutral. In the second decade, there's about a 1.5 of that 8 trillion is the reduction. In the third decade, it's 6.5. So there's a real powerful tail. And why is that? It's because over time, as that raising of the Medicare eligibility age kicks in, that becomes more powerful in the third decade, and the fourth decade, and the fifth decade, because all of a sudden, that population now, the lower end income-wise is getting subsidized, but the upper end is not. And that difference alone is the majority of the difference in terms of deficit reduction. There are some other things in there too, but that's the biggest driver. It's not the changes on the exchanges and things like that that are driving it. It's really this Medicare component. Because actually on the Medicaid side, I'm spending a little bit more money because exchange-based coverage does cost a little more than legacy Medicaid spending. So I'm actually spending more money on the poor in this plan, but spending a lot less on upper income retirees. But what's the consequence of that? The Medicare Part A trust fund is permanently solvent under this approach if this deficit reduction is used to fund the Part A trust fund. So not extended for another 8 years or 4 years or 10 years or whatever it is. It's permanently solvent. That's a big deal when you think about the large $100 trillion unfunded liability for Medicare and Medicaid. And of course, on the Medicaid side, if you rationalize the way we pay for Medicaid, that allows states to get control of their budgets again, because that's a big problem for states today, is Medicaid is crowding out other important priorities like education, policing, and roads. Here are some of the really nice things about this approach as modeled by Steve, is we actually cover more people in the ACA. Why? Because while we don't get back down to the pre-ACA level prices in the individual market, the liberalization of the exchange does chop off a good chunk of the cost increases on the post-ACA exchanges. And not just for individual market, this is for all commercial premiums. This includes the employer market as well. And what does that mean? If you actually make insurance less expensive, more people want to buy it, and so you actually get more people covered. And because you're transitioning people out from Medicaid into the commercial insurance market where their access to providers is substantially better, you get better health outcomes for the poor than you do for the system we have today. So why is this set of answers attractive? It's because you can actually allow conservatives and progressives to both achieve goals that are important to each. So what does it progressives care about? And you can correct me if I'm wrong, but progressives I know really are passionate about making sure that every American is protected from the economic insecurity that comes from not having health coverage, and also that we make sure that the most vulnerable people in our society are protected as well and have that basic economic access to the healthcare system. What do conservatives care about? They care about the spending. They care about the deficit. They care about government intrusion. Well, you can actually achieve both of these things through an approach like this. I mean, you know, in most policy environments, in most issues, one side has to win and one side has to lose, but our healthcare system is so messed up that both sides can actually win at the same time. And so in my, Scott mentioned as he introduced me that this plan has been criticized by people on both sides. It's also been praised by people on both sides as well. And look, you can't put out a health reform plan without people not having criticisms of it, and that's fine. I embrace that because I actually want to learn from people and try to see what I can do to make it even better than it is. So with that, I know I've been going on for a long time. I thank you for your patience, and I look forward to your questions. You can download the full plan here and email me if you find anything wrong with it. Thank you very much.